Good morning. So just a couple of minor administrative details. First of all, I think I may, in the way I've created the slide sets for today and for Monday, they may well be backwards in the order in which I'm presenting them. So if that's the case, I apologize in terms of the numbering. There are two sets of slides relating to randomized controlled trials in individuals, and I'm not totally sure I have them in the right order. So whether they'll show up on the right order on the. Okay. The other thing is, I gather that in the fairly rushed presentation about measures of association and measures of potential impact, I may have created some anxiety. These are, in fact, the central issues that we worry about in analytic epidemiology. We will revisit all of them as we talk about these analytic epidemiologic study designs, particularly odds and odds ratios, but also attributable risk and things of that kind. So this was to give you a first exposure to these concepts, but we will be revisiting them over the next several weeks, and you're certainly going to have an opportunity to explore them in the discussion section as well as to read about them in the textbook. But the types of studies we're talking about now for the next several weeks, analytic epidemiologic study designs, are fundamentally intended to help us measure these measures of association, things like risk ratios and rate ratios and odds ratios, and these potential measures of potential impact, these attributable risks, population attributable risk, and the exposed attributable risk. So in essence, when you think about these different study designs we're talking about, that is the intention, to try and calculate in an unbiased way these particular measures. Okay? And so I've already alluded to the fact that when we are interested in testing hypotheses about exposures and outcomes, we fundamentally have two types of studies at the individual level. We have experimental study designs and observational study designs. And the experimental study designs we'll talk about today, Monday, and next Wednesday. And they basically fall into really two types. Individual level studies, where we randomly assign individuals to one exposure group or another, and group level or cluster randomized studies in which we randomly assign groups or communities to one exposure or another. Clinical trials really refers to the fact that many of these types of studies, these studies really were begun by clinicians interested in knowing whether one drug was better than another drug, one treatment was better than another treatment, or at least equivalent to another treatment for treating a particular disease. So that when we talk about clinical trials, we're generally talking about treatment of an illness, as opposed to field trials, which I generally use to refer to the kind of prevention activities that public health is more interested in, things such as vaccine trials or trials of a nutritional intervention or a behavioral intervention, or something of the kind, something intended to prevent disease or injury in the first place. Okay, so these experimental study designs are the most similar to the laboratory studies that are done on animals, but are constrained by the ethical and logistical considerations implicit in studying human beings. And so by definition, although there are many, many challenges to working with animals, and there are many people who object to animal research, so there are many constraints on animal research. There obviously are constraints on what we can and cannot do to human beings. And Mahasan obviously gave you a very brief introduction to some of the ethical lapses of prior epidemiologists and public health people. And so there are many, many restrictions on what you can and cannot do when you're working with people. But the sine qua non of experimental study designs is the randomization. That is the fact that people don't self-select into one group or another. We put them into one group or another the same way we might with mice or fruit flies or whatever it is. And so this idea of randomization, and people tend to use this indiscriminately to also refer to random selection. And so when we go out and do various types of surveys, we'd like to randomly select people. Those are rather two different uses of this word random. But randomization really refers to the process of putting participants into different groups through a process by which all participants are equally likely to be assigned to either the intervention or the control group. And you could envision it being something similar to tossing a coin. So when it's your turn to be assigned to one group or another, I toss a coin, and heads you end up in one group, tails you end up in another group, except we don't tend to use coins anymore. We tend to use computers and fancy random number generators. The advantage of this random assignment is that if you randomize enough people, it removes the potential bias in the allocation of participants, and it tends to produce comparable groups such that both measured and unmeasured factors and characteristics of the participants at the time of randomization will on average be evenly distributed among the groups. Okay? So if we randomize enough people, the two groups will be very, very similar with respect to their characteristics. And that assures the validity of the statistical tests of significance. I guess my pointer is not working too well this morning. The validity of the statistical tests of significance, which people then like to apply to epidemiologic data. And as I've already mentioned, in general, we can only ethically randomize people or groups of individuals when we think we have something beneficial to offer them. And it is generally unethical to randomize people to what we think might increase their risk of disease or injury. And of course, there's also the obstacle that people might not be very interested in being randomized to something that increases their risk of illness or injury. So there's both the ethical piece as well as the practical piece. And so you sort of, we can't quite do this to people as is shown here, exposing them to cell phones or caffeine or tobacco or whatever it is, if we think that those are harmful exposures. If we already have information suggesting it's harmful, you can ask the question, is it ethical to randomly assign people to different noxious exposures? And then, of course, there's always the possibility of getting sued. Okay. So I want to show you, however, at least a couple of examples where people have, in fact, randomly assigned people to what they believe is going to be an increased risk of disease, and presumably they actually had the approval of what we call human subjects committees, IRBs, to do these studies, and we could argue whether these were ethical studies or not. Obviously, the IRBs thought they were. So this refers to the fact that we frequently have closures of beaches in the United States. And why is that? Why do we sometimes close beaches for public health reasons? Because there may be fecal contamination of the water, so sewage, untreated sewage, may make it past the treatment plant, end up contaminating the water in a beach, and we're worried that swimming in the water will pose a risk to your health, right? So, and that's a major problem for beach communities and for surfers and all kinds of other people in terms of these beach closed, avoid water contact sorts of events. So this is an interesting study done by people in the UK about 15 years ago, which basically randomized people to swim in contaminated water or not swim in contaminated water. Okay, now presumably they had a hypothesis that going into contaminated water was not good for your health, and they randomly assigned people to go into the water or not go into the water, and then they measured their risk of various ailments, particularly skin rashes and ear infections. Okay, now was that an ethical thing to do? It's not my study, I'm not here to defend it, but I think their argument was that they in fact took people who were planning to go into the water anyway, and they randomly assigned half of them to stay on the beach. So that they in fact randomly assigned half of them to an exposure that might reduce their risk of disease. Therefore, since they were all planning to go into the water, this was an ethical thing to do. I'll leave that up to you to decide if you think that's a reasonable justification or not. But here you can see just one result of this study, acute febrile respiratory illnesses among what the British cleverly call non-bathers and bathers. That's people who don't go into the water and people who do go into the water, by the number of fecal streptococci in the water. So they actually measure how much fecal contamination there is in the water, and there's a lot in some areas and less in other areas, and then they see what your risk of getting, in this case, what we might call the common cold, febrile respiratory illnesses, is, and you can basically see that your rate generally is fairly high and is certainly higher than if you didn't go into the water at all. Okay, so this is an example of randomizing people to what might be a noxious or exposure or something that increases their risk. And this actually plots the probability, in this case, of an ear infection versus the fecal coliform density in the water, showing that the more fecal contamination in the water there is, the greater your likelihood of getting an ear infection, proving their hypothesis, presumably. Okay? Now I want to show you one other one, and this one I think is actually potentially a little more troubling. So this is a study done by Ken Rothman, and many of you may know that Dr. Rothman is one of the world's preeminent epidemiologists. He's written some of the classic textbooks. And so here the research question, if you will, is does vaginal douching increase the risk of pelvic inflammatory disease? And the background information given in the paper that he wrote said, several epidemiologic studies, n equal 4, but not all, in other words, one didn't, have reported a positive association between vaginal douching and the risk of pelvic inflammatory disease. In a meta-analysis, douching was related to an increase in risk of PID of 73%. So what this basically tells you is that the observational studies of the kinds we'll start talking about the week after next suggested that women who douched had a greater risk of this very, very serious health outcome, pelvic inflammatory disease, which is associated with infertility and a variety of really quite severe consequences. And despite that, a decision was done to do a randomized trial of women between the ages of 18 and 34 to randomly assign them to a group that would agree to douche and a group that would be assigned to wipe. Now, is that an ethical study? Don't ask me, not my study. I'm simply showing you an example of where multiple human subjects committees, in fact, approved this study. So when you go back to the question of what's ethical and what isn't, ultimately people may disagree about that. I think some people would argue this was not an entirely ethical study. If you truly believed that this exposure increased the risk of this serious adverse health outcome, that maybe it wasn't ethical to randomize women in this way. But this was approved, and you can see that altogether there were about almost 1,800 women randomly assigned to one group or the other. This will simply show you in his textbook on epidemiology what Ken says. Experiments on human subjects are ethically permissible only when adherence to the scientific protocol doesn't conflict with the subject's best interests. Specifically, there should be reasonable assurance there's no known and feasible way a participating subject could be treated better than the treatment possibilities the protocol provides. From this requirement comes the constraint that any exposure treatments given to subjects should be limited to potential preventives of disease. So I'll leave it to you to decide if this study met that or not. The good news, I guess, from this study is there turned out not to be any difference at all between the women in the two groups in terms of their risk of pelvic inflammatory disease. And so you could say that, in fact, no one was harmed, that, in fact, the two groups, and this is cumulative risk of PID by which group they were in, and there was basically no difference. And so we're going to talk about this later in the semester. We frequently have situations where observational studies, such as cohort studies and case control studies, suggest an association. And then when a randomized control trial is done, no relationship is found. And so this is true, for example, in terms of estrogens in postmenopausal women and a variety of health outcomes. And it's a particularly troubling problem in terms of when we can believe observational studies, when do we need randomized trials to answer a question. And so here you can just see that basically these are now hazard ratios and basically showing that there was really no difference between the women who douched and the women who didn't. And so you could argue that no one was harmed by that study, but that might not have been obvious when the study was being planned. Yeah?
How is this, if these women did this on a regular basis anyway, how is this any different from studies?
So if you took women who regularly douche and randomized half of them to not douche, you could argue it's just like that bathers study. That you know, you're randomly assigning women to an exposure that might lower their risk compared to what their normal practice is. Okay, and so I think in that sense, and I don't actually know whether I'd have to go back and look whether these are women who ordinarily douched or not. Your question is a little bit different though, because studies of smokers, people who smoke choose to smoke. If I follow smokers over time and compare them to non-smokers, I haven't randomly assigned you to smoke. And if I tried to randomly assign you to smoke, there's a pretty good chance you'd refuse. right? If I said, I'm going to randomly assign you to start smoking 2 packs of cigarettes a day, there's a pretty good chance you wouldn't agree to that, right?
Back in the 50s when people didn't really know this
Right,
actually bad.
right.
I'm talking about the ethical considerations in a situation where you don't really know what the effect is.
So if you truly, and that's we'll talk about that, something called equipoise. If you truly have equipoise and don't know which exposure is better or worse for you, that is generally a circumstance in which it's considered ethical to randomly assign people to one group or another. The question is, when do you have equipoise, and people can disagree about that, right? But the smoking issue, I think, is a little bit different, and I think it raises the question of what are the ethics of following people over time who are doing something who you think is really bad, that you think is really bad for them? Are you ethically obliged to try and get them to stop? Okay? And so we'll talk about that when we talk about some HIV vaccine trials and other trials of sexually transmitted infections, where you could argue that people are putting themselves at risk. The investigator knows that they're putting themselves at risk. What's their ethical obligation to try and prevent that risk, even though they're not being randomized? Okay? And these are very, very difficult issues. Okay? So some overarching issues about randomized trials. Randomized trials are typically very complicated. And they take a long time to plan and execute. In many instances, they are very expensive. So the ones I'm going to show you on Monday, you'll get a sense of how expensive they can be. And they pose lots of administrative and ethical challenges. And there are many, many, many decisions that have to be made when planning a randomized trial. So obviously, one of them is what treatments or interventions you're going to test, how many different treatments and interventions. If it's a drug or a vaccine, what dose or doses will you test? What frequency of administration will you test? What will be the route of administration? So this one simple example, where I'm going to show you an example of a factorial design and explain what that means. But factorial designs are very clever randomized studies in which you can try and look at a number of different exposures all in the same trial. Who's the right study population in order to answer a question? A key question is always, how big of a sample do you need? How will you actually randomize people and allocate them to different exposure groups? How important is it, and is it possible to blind people? Ophthalmologists don't like that term, by the way. Ophthalmologists prefer to talk about masking people. They don't like to talk about blinding people. But can you mask the study participants in terms of which study group they're in? Can you mask the investigators who are following up the participants in terms of what study group they're in? And that's possible sometimes and not in others. Is it ethical to use a placebo? And what are the ethics involved in giving people a placebo? And that's a very controversial issue. What are the study endpoints? So are you trying to prevent heart attacks? Are you trying to prevent death? What exactly are the endpoints you're studying? A key question is, do you need a data safety monitoring committee that occasionally looks at the data and determines that a study should be stopped early in order to avoid further harm to study participants, either because the study's already shown an effect or because it's clear that continuing the study is futile and it can't possibly show an effect. So should you stop the study early? So stopping rules. Under what conditions would you stop the study early? How long do you need to follow up people, and what are the methods for following people up? How will you collect, manage, and analyze the data? Obviously, in addition to the ethical obligations, there are questions about the informed consent process. What do you need to tell people? What can you do to assure that they actually understood what you told them? Because the common approach in the past has been someone signs a consent form. How many of you have signed a consent form? Frequently in a clinical setting, even for some kind of procedure, you have to sign a consent form. Do you read them? I never read them. They go on for pages. You know, to have an x-ray or whatever, I've got to sign a 12-page single-spaced form. You know, and if I don't sign it, I'm not going to get the x-ray. I just signed the damn form and, go get the x-ray, right? So it's the same thing in studies. These forms are increasingly long and complicated, and so do people actually understand them if they read them? Okay, yeah.
What about randomized studies where you have control and study groups? Placebo effect
Right. So one question is, when you have an active ingredient, a drug or a vaccine, to give to one group, is it okay to give the other group nothing? Or should you give them a placebo so that you can mask them in terms of who got the active ingredient and who got nothing? If they get nothing, they obviously, it's easy to tell who got the active ingredient and who didn't. If you give them a placebo, then in theory, they can't tell which group they're in. Although, unfortunately, some active ingredients have side effects, people can frequently actually guess whether they're in the active ingredient or the placebo group. So you have to formulate the placebo in a very informed way. But the point of the placebo is to basically account for what's called the placebo effect, that giving somebody anything tends to have a beneficial effect on many health outcomes.
So my question was, so does statistical measures kind of account for that, kind of try to eliminate that?
Well, so the studies end up looking at what is the effect of the active ingredient compared to not having the active ingredient, and basically whatever the placebo effect is, presumably is there for everyone. So it's not a question of statistical measures, it's basically the biology that's sort of already there for everyone who's in the study, whatever that placebo effect is. Okay, and if you are doing a randomized trial to support licensure of a drug or a vaccine, and obviously companies that are trying to market a drug or a vaccine want it licensed by the FDA in the United States or comparable agencies, all of these processes are incredibly rigidly constrained by what the FDA requires. And in fact, I was just at Kaiser last week meeting with some of my colleagues there. They were about to have a visit by the FDA to go through every scrap of paper from one of their studies and to see if, in fact, they had met FDA requirements. Okay? So the FDA, one of their jobs is to make sure that studies used to license a product are administered in exactly the correct way, and if you don't do it their way, those data cannot be used in support of licensure. Okay? So they actually take quite a bit of the flexibility out of this. Okay, Mahasan, to a certain extent, has talked about these principles governing research on human subjects, respect for persons, beneficence, and justice, but these are obviously critically important in the context of randomized controlled trials, and it's respect for persons. This is the principle that leads to the need for informed consent. These others are the one, this beneficence relates to the fact that in essence we want to maximize benefits and minimize the harms to anyone who is a participant in a study. And justice basically relates overarchingly to the question of are the people who might benefit or suffer the risks of a study equally likely, are the risks and benefits going to be equally distributed, or will some people assume all the risks and other people derive all the benefits? Okay? And this is a very complex area. There are entire courses on the ethics of human research, which I clearly can't get into in any particular depth here. A key question is what's called the therapeutic misconception. And the therapeutic misconception refers to the fact that people generally assume that somebody in a white coat is looking out for them, and that your doctor, your nurse, your nurse practitioner, whomever it is on your side, and that if they suggest something, that's in your best interest, right? And I think we all generally like to assume that. And patients also, people tend to assume that anything that's new and experimental is better than something old and regular, right? So you certainly, and that's sort of reflected in, I believe, this cartoon, the last thing in the world you want is to be in the placebo group, right? You know for sure you want the active ingredient because that's got to be better than getting a placebo, right? I think most of us suffer from this illusion, right? But in fact, if there truly is equipoise, if we truly don't know which is better, then there is a chance that you are better off in the placebo group, okay? And in fact, this is a list of past mistakes, if you will, or problems in which you would have been better off in the placebo group in terms of in these studies, okay? That is that people have tested something that turned out, in fact, to increase your risk of a harmful outcome for one reason or another. And in fact, there are increasingly, as people do more and more tests of, for example, medical devices, subject things like stents to prevent strokes, it's increasingly clear that new devices frequently, in fact, increase your risk of a bad outcome, and you are not necessarily better off getting what's new and experimental. But that's what all of us tend to believe, that we don't want the placebo, we don't want what's old, we want what's new and supposedly better. Yes?
So in a study like that where the drug has been proven to be effective, do they disclose that in the consent?
Do what?
Do they disclose in the consent form that maybe?
Well, in theory, on any consent form that's properly constituted, the risks and benefits are clearly laid out. The problem is, in order to do that, there's more and more language. Consent forms get longer and longer and longer and longer. They become fuller and fuller of technical information. People tend not to read them, just like I don't read them. Okay? And in fact, if you do studies looking at how much do people understand, they in fact don't tend to understand very much from what's in the consent form they sign. Now that people are actually studying that, it's pretty clear that signing a piece of paper in no way implies you actually understood. So concepts like randomization and placebo, two very, very important issues, are not intuitively obvious to everyone, particularly people who don't have a lot of education. Okay? So people can sign a piece of paper or make their mark or an X or whatever it is. That doesn't mean they actually understood what they were signing up for. Okay, so just going to take a couple of examples to illustrate this point. This is, many of you know, as I said the first day, that the HIV epidemic is one of the world's most important public health problems, with about 36 million people currently infected with HIV. We have a number of effective ways of preventing transmission. We don't have a vaccine, and what we desperately need is a way to prevent heterosexual transmission of HIV, particularly one that women can control themselves. Male condoms work, but male condoms require a high level of participation by men. And women need a female-controlled method. And so this has led to an enormous amount of research on what are called microbicides. Okay? So microbicides are basically materials that a woman can insert prior to intercourse that would kill HIV and prevent transmission of HIV. Right? So one of the very early studies of a microbicide was naloxone 9. So if some of you probably use a naloxone 9 product, naloxone 9 is a spermicide. So it's in contraceptive sponges and in contraceptive gels. It is approved for use. It has been established to be safe when used in vivo. And when people studied it in a test tube in vitro, it was shown to have activity against the AIDS virus and other sexually transmitted infections. So in a test tube, it inhibits these viruses, and therefore people thought it's safe. We know it's safe. In vitro, it seems to kill HIV. Let's do a randomized control trial to see if it prevents HIV infection. Okay? So very, very important if we can discover a microbicide. And so in whom would you do this type of randomized control trial? You would presumably have to do it in high-risk women. If you choose women who are at no risk of HIV infection, neither group will have any HIV infections, and you won't know if the microbicide works, right? So in general, for these types of studies, you have to take people at very high risk, and in this case, it was decided to use commercial sex workers, okay? And that turns out to be an interesting problem. But here you can see you have to take a bunch of commercial sex workers. You have to make sure they're HIV negative. These are in various countries. And then you randomly assign them to get a gel that has or doesn't have naloxone 9. You are obviously ethically obliged to do everything you can to prevent HIV infection in these women. So you give them condoms. You give them health education materials to try and get them to reduce their risk. But these are sex workers, right? And then you have to treat their other sexually transmitted infections, and then you follow them over time. And so this is pretty much what you see in a randomized controlled trial: how many women got screened and excluded, how many were enrolled and randomized, how many get analyzed, how many didn't have follow-up, so that you can see exactly what happened every step of the way. And that's very important in randomized trials to sort of demonstrate who got excluded and why, who got lost to follow-up, et cetera. So you can see here they start out screening about 2,200 women. They end up with about a little under 800 women in the analysis. And what this shows is you also generally are obliged to show, are the women or the participants the same at baseline? Did the randomization work to assure equal groups at baseline? And this basically shows that in terms of age, number of clients per day, years of education, condom use for more than 50% of sex acts, that the two groups were in fact identical in terms of all the various things you'd want to know about them. Yes?
How do you make the decision to only use the people that you followed up with in your analysis? Because here you would think maybe there's something about the people that didn't come back to follow up.
Right. So a key question is, first of all, what can you do to minimize loss to follow-up? And how different are the people who are lost to follow-up from those who stay in the study? And what biases, a form of selection bias, is introduced when you, in fact, can only study those who stay in and you have a lot of loss to follow-up. And it does introduce selection bias. But if you don't have information, if you don't have follow-up information on people, there's no way to include them in the analysis. So we'll talk about that later when we talk about selection bias, but it's a big problem if you have a lot of loss to follow-up. Okay? So this just shows that the women were very similar in the two groups at baseline. And this is the bad news from this study. The noxinol 9, the women who had the noxinol 9 actually, so this is the number of infections over the number of women. So this is the incidence per 100 women years, so this is incidence density for HIV infection. So almost 15 per 100 women years in the noxinol 9 group, 10.3 in the placebo group, a hazard ratio of 1.5, a statistically significant increased risk of HIV infection in the women using the noxinol 9. Okay? So not only did the noxinol 9 not prevent HIV infection, women who had the noxinol 9 were at greater risk. This is one of those studies where you would have been better off in the placebo group. Okay? This was an enormously disappointing study. Since then, as many of you know, we do have some vaginal microbicides that have been shown to work using antiretrovirals in the microbicide. But this study was obviously a great disappointment. Now, if you're asked the question, why did this, what can you interpret from this study? Or why did this happen? So it kills HIV in a test tube, but in vivo, inside women, actually the risk is greater in women who are using this material. Yes? Yeah. Exactly. So the concern is that the chemical action of this noxinol 9 on the vaginal mucosa may have damaged the mucosa and actually facilitated transmission of infection. And in this particular group, why might that be true? And it might not be true in the average woman who's not a sex worker. Because these women are using this product multiple times a day. They're having multiple sex acts a day. That's their job, if you will. And a woman who has sex once a week may not have the same effect. But it's very difficult to do the study in very low-risk women because you won't have enough HIV outcomes to study. But there's a concern that this is not representative of what would happen in women who are using the product once a week as opposed to 4 or 5 times a day. That the effect on the vaginal mucosa might be very different. Yes?
Is it routine to go from laboratory to large RCT? Usually there's some steps.
Well, so is it routine to go from laboratory studies to large RCTs? Well, in the area of vaccines and drugs, the answer is no. We have what are called phase 1 studies, phase 2 studies, phase 3 studies. But this is a material which was already approved by FDA and known to be safe when used as a vaginal spermicide.
Right, but not for this indication.
Not for this indication. So did they short-circuit something and going directly to this? Is that a problem? I suppose you could find people who would disagree about that. Obviously, the HIV pandemic is considered, if you will, an emergency of a kind, and we desperately need a female-controlled method of preventing HIV transmission. But I don't think people feel a step was skipped here, that we knew the material was safe. Women were using it all the time as a spermicide, so why not see if it prevented HIV transmission? Yeah.
So there's blind control studies, and then there's also double-blind studies where the experimenters don't know who got the placebo and the true
Right, so this was a double-blind study, and so the women didn't know which group they were in. Women either got the microbicide-containing gel or a gel that looked just like it but had no, and that's another whole methodologic issue. Should you actually compare this to a gel that doesn't contain microbicide and that might lubricate, or do you compare it to nothing? And that's another methodologic issue. But neither the women nor the people following the women over time knew who was in which group. So this was double-blind.
So how were they able to track, the diagram before, like exactly following those two ones? How were they able to do that after the fact, or?
How do they do what?
On the slides before, you showed a diagram of, experimenters keeping track of.
Well, they know who's in group A and who's in group B. They just don't know whether group A is the microbicide or group A is the placebo. Right? They know who's in which group. They just don't know which group got the active ingredient and which group got the placebo. Is, I think, the answer to your question. Okay, so you can see in this study, users of Noxil 9 had an increased hazard of HIV-1 infection and weren't protected against either gonorrhea or chlamydia. Okay, now, as I've said more recently, in fact, earlier this year, there have been finally the results of the CAPRISA and other studies showing that a vaginal gel containing an antiretroviral drug, in fact, is at least partially protective against transmission of HIV, bringing a lot of optimism, if you will, to the possibility of creating a vaginal microbicide. And that was also a randomized control trial. Okay, so some other issues that are important as we think about randomized control trials. First of all, as just represented by the study I just showed you, are the people in the trial representative of some larger group? And of whom are they representative? So commercial sex workers in these studies may be representative of other commercial sex workers. They may not, they're almost certainly not representative of women who are not commercial sex workers, right? So that's a huge issue in terms of interpreting those studies of microbicides. It also turns out to be an issue in terms of studies of estrogens and various cancers and heart disease in postmenopausal women. What's the frequency of the outcome that you're studying, and how big of a sample size do you need? Is it feasible to enroll enough people of the kind you want into your study? And how feasible is it to follow people up? So, for example, in many HIV studies, the group we might want to study are injection drug users for a variety of reasons. But how difficult are injection drug users to follow over multiple years? Because they tend to have other priorities than showing up for your study on a regular basis, and they can be very, very difficult to follow. A large amount of loss to follow-up introduces this problem of selection bias. And then, of course, there are obviously ethical considerations, as we've talked about. Now, here's another example of a question about choosing a study population. Again, an HIV vaccine trial. Who would you put into an HIV vaccine trial? So when you come up with what you think is the right vaccine against HIV, who can be in the trial? Presumably, it's people who are at very high risk of HIV, but who are not yet infected. And the major group that those studies involve have either been injection drug users or men who have sex with men in high-risk communities, right? So you can therefore, if you use a very high-risk group, you can have a higher incidence of the outcome. You can end up with a smaller sample size, but they're more difficult to enroll and follow over time. And as we said with these microbicide studies, women with a higher incidence give you a smaller sample size, but the effect may be very different in women using the product different numbers of times a day or a week. And so here is this question about equipoise. Equipoise is a state of genuine uncertainty about the benefits or harms that may result from each of two or more regimens. So in theory, there must be equipoise before you can randomly put people into one or more groups. And there can be a lot of arguments about when we are in equipoise. Do we truly know that douching is bad for women? Well, obviously Ken Rothman didn't think we did, and that there was equipoise and that it was ethical to randomly assign women to that exposure. But that's, it's easy to cite these principles. It's much more challenging to agree on their application. This just simply refers to the fact that internationally there is a huge debate about the role of placebos in randomized control trials and when is it ethical to have a placebo. And so this gets to be quite a complicated issue, particularly in studies done outside the United States. A related issue is, what's the standard of care that all study participants should be promised? Okay? So if I do an HIV vaccine trial in a sub-Saharan African country with limited access to HIV care, and someone acquires HIV infection while in my study, either because they're in the placebo group or because the vaccine doesn't work 100%, what kind of HIV-related care are they entitled to? So they're in my study, they acquire HIV infection while in my study. What's my ethical obligation in terms of treating them? Pardon? Provide treatment. So what kind of treatment should I provide them? Pardon?
Treatments that aim to prevent other infections.
So to prevent opportunistic infections. What else? Am I obliged to give them antiretroviral treatment? Am I obliged to give them the same standard of care that U.S. HIV-infected people get, if that's somehow better than the standard of care in the country where they live? Am I obliged, how long does HIV infection last? For life. Am I obliged to treat them for life? So most people would say, yes, you're absolutely obliged to treat them, or at a minimum to refer them for treatment. But this can get to be a very, very tricky business, particularly when we worry about whether we offer people unfair inducements to participate in research. What if the only way they could get access to good care in their country is to be in my study? Is that an unfair inducement that coerces people to participate in a study they might not otherwise want to participate in? So how do you balance your ethical obligation to provide care without offering unfair inducement? These are very, very difficult issues in the real world. Obviously, a key question is, how much should study participants be told about the study, and what do you have to do to assure that they understand the potential risks and benefits, that they understand randomization, that they understand placebo. And increasingly, there's an obligation not only to get signed informed consent, but to document through some sort of test that people have actually understood what they just signed, what the risks and benefits are. And in poorly educated communities, that can be quite challenging with some of these complex issues. Okay? Again, under what circumstances should a study be stopped early? What commitments should be made concerning future access to treatment or interventions that prove to be beneficial? So suppose drug company A goes into Uganda and tests a new vaccine and proves that it works. So they use Ugandan subjects to prove that a vaccine works, let's say an HIV vaccine. Do they have any ethical obligation to provide the vaccine to Ugandans? To which Ugandans? Generally, people would say they're obliged to provide it to the placebo recipients once they know that it works. What about to everybody else in the community? Are they ethically obliged to provide it to everyone else in the community, or is that somebody else's problem? People in the community assumed the risks of participating in the study. What benefits is the community entitled to as a result? And I think you can imagine if you tell the company, in order to do the study in our country, you're going to have to provide it to the entire country for free, and maybe forever. That could potentially be a disincentive to conduct research if you make it very, very expensive, right? So another sort of just complicated issue. Another question when we talk about community interventions, where we randomize communities instead of individuals, who provides consent on behalf of a village or a city or a school? And do you have to get individual level consent in addition to consent on behalf of the community? So another challenging issue. Okay? This is an example of a study. This is another microbicide that also failed an earlier study where, in essence, the Data Safety Monitoring Committee determined that the women with using the microbicide were at greater risk than women not using the microbicide, and they ordered the study be stopped early to prevent harm to additional women. That's the importance of a Data Safety Monitoring Committee and having stopping rules. This is unfortunately the study of the Nancy Padian study showing that diaphragms don't protect against HIV infection. And this is a study done that was stopped early because of benefit. So I showed you the ecologic data that the prevalence of male circumcision correlates at the ecologic level with the prevalence of HIV infection, right? And there were also observational studies, cohort and cross-sectional and case control studies showing a relationship. But people basically, some people were not convinced that male circumcision was protective against HIV infection, and they said there had to be a randomized controlled trial. Okay? So could you do a randomized controlled trial of male circumcision here in the United States? Some of you may know, by the way, we're about to outlaw male circumcision in San Francisco. There's a proposal to outlaw male circumcision in San Francisco. We Jews are up in arms about it, but Muslims too, perhaps. Could we do the trial here in the United States?
Right now, or before this?
Before the study. Why not? I would say we can't. Why can't we?
Because the population of people that are circumcised in the U.S. is very different from the population in the other.
So the study results here might not be representative of another country. That's true, but I'm asking, could we even do the study? When do we circumcise in the United States? God told us to do it on the 8th day if you happen to be a Jew, okay? So we circumcise at birth in the United States. How many of you do you know of people being circumcised at adolescence in the United States? So if we did a randomized controlled trial of babies, okay, how long would it take to get an answer? We have to wait for them to grow up, become sexually active. It's at least 25 years. And because the incidence of HIV in men in the United States, at least heterosexual men, is so low, the study would be astronomically large, maybe even bigger than the whole birth cohort of the United States. Okay? So that doesn't work. So where could you do such a study? I initially said, you're nuts. You can't possibly do a randomized controlled trial of male circumcision. I was completely wrong. There have been not one, not two, but 3 RCTs of male circumcision. So what characteristics would a community have to make this possible? Pardon?
A community where they don't circumcise traditionally, or if they do, it's not so later.
Exactly. And in fact, because communities that don't traditionally circumcise probably are unlikely to agree to participate in the study as readily, communities were chosen where circumcision is not done in infancy, it's done at adolescence. The cultural practice is to do it at adolescence in a number of African tribes. So you go to those settings in Africa, you get adolescent men, young boys, whatever you want to call, people at that age, to agree to be randomized to be circumcised or not. And they're obviously about to become sexually active. You don't have to wait as long. And these are areas where there's a lot of heterosexual transmission of HIV, so the outcome is much more common. And they're the group you're most interested in extrapolating the results to. Okay? So 3 of these studies were done. And in fact, the Data Safety Monitoring Committee ordered that the studies be stopped because of the dramatic decrease in the incidence of HIV infection in the circumcised men. And in fact, while the initial estimates were in the range of around 50%, currently with longer follow-up, it's closer to 65%. The protection of men by male circumcision against HIV infection is close to 65%. If we had a vaccine, an HIV vaccine that was 65% effective, we would be using it, right? So this is just one of those studies done in Kisumu in Kenya. And here you can just see, so this is the risk ratio in HIV incidence follow-up. These are the circumcised men, these are the uncircumcised men, and at 2 years, as I've said, the risk ratio was 0.47, so about a 50% reduction, but actually further follow-up now shows it's closer to 65%. Yeah. Do we know why? Yes, we do know why. It turns out that the male foreskin is rich in cells that have an HIV receptor. So there's biological plausibility to this because of these cells with an HIV receptor that are multitudinous on the male foreskin. Okay? So there is a biological plausibility to this as well. Okay? But so here, this study was stopped early because of benefit, not because of harm, but because of benefit. Yes?
Just in terms of the ethical nature, if a Luo people do not circumcise, traditionally circumcise, those are people who sued. So they're not traditionally.
You're saying they don't traditionally circumcise? Okay, so you know more about it than I do, but
But just because it is a cultural issue, like inside of
And so you can imagine where it's reasonable to try and do this study, both ethically and practically. Obviously depends on exactly those types of issues. And I'm certainly not an expert on the luau of Kenya, so it sounds like you know more about it than I do. But this illustrates the fact that sometimes we stop studies early because people are being harmed. Sometimes we stop studies early because there's so much benefit we don't want to expose the placebo or the control group to any additional risk. Okay, so we're going to come back and finish up on this, and then I'm going to show you some other important randomized trials on Monday. Okay?